All right, so good morning, everyone. Thank you so much for attending this month's Equity Matters. We appreciate you. We realize that this month is Domestic Violence Awareness Month and Breast Cancer Awareness Month. So to honor that, we decided to have a Equity Matters that discussed the intersectionality between breast cancer issues and domestic violence. I was actually surprised to find out that there is a lot of information that talks about how each actually impact one another and the increase in numbers for those who deal with breast cancer and domestic violence, or as some may call it, intimate partner violence. So today we have on our panel, we have Ms. Mandy Horvath.
Hooveris.
Hooveris, Miss Mandy Hooveris. I always pronounce your name incorrectly, and I do apologize. Mandy is our community engagement director and our outreach director for the New Hanover County Domestic Violence Shelter. She works in New Hanover County. It's not the New Hanover County Domestic Violence Shelter. And we have Dr. Tracy Ray. She represents Safe Haven of Pender. And so that is the domestic violence shelter in Pender County. And we also have Sarah Arthur, who is the Director of Community Health for Novant Health, formerly New Hanover Regional Medical Center. And she will be speaking with us on behalf of the breast cancer, our breast cancer consortium. So we want to just welcome everyone, and we'll go around and get your bios and talk with you today. Mandy, thank you for coming to us. Tell us about who you are and how long you've been in Wilmington.
Yeah, thanks, Fawn. I'm a townie. I'm one of the few folks who were born and raised in Wilmington. And so it is a privilege to be here and serve this community that I care a lot about. I started at Domestic Violence Shelter and Services as an intern a long time ago, back in 2007. And I've been doing this work ever since. I really fell in love with the mission and the services provided by our agency, but mainly this population. And so, I oversee the direct services at the Open Gate and connect with our community.
I appreciate you. Thank you so much. And thank you for the work that you do. And thank you for being a townie. As you said, I like that term for us. And now we move to Dr. Tracy Ray. Tell us who you are and what brings you to our stage and your connection to Wilmington area.
So I'll have to start like Mandy. I'm a townie of Wilmington. I actually live in Burgaw. I moved away for a little bit, and so came back to Pender County for this work. I was invited to work with our previous director at Safe Haven. And I've been there for probably about 15, 16 years now, doing various things, not in this role the entire time. I am a survivor of teen dating violence way back when, unfortunately, no one was talking about it. So I consider this a part of my life's mission to move our work forward, to be a part of the process, I should say, to move this work forward with responding to the needs of victims and survivors. So I'm excited to be here to have this discussion. It's very necessary. Thank you for creating the space to do that. And I feel honored to be on this panel. Thank you.
I appreciate you. Thank you so much. And then we have Ms. Sarah Arthur. Sarah Arthur, tell us about who you are and what brings you to the panel, and your passion also.
Thank you for having me. Sarah Arthur, Director of Community Health with Novant Health. I have lived in Wilmington for about 12 years. I'm originally from Greensboro, North Carolina. I'm a social worker by training and currently oversee all of our community health workers throughout the Novant Health system in Wilmington, Winston-Salem, and Charlotte. And then also get the pleasure of working on quality initiatives as it relates to our institutes like our Cancer Center and connecting the dots between community partners like the health department or FQHCs and how we could truly collaborate to make sure we're serving the needs of the patient and the community. Thank you for having me.
Oh, it's no problem. I appreciate you. So let's go ahead and get started and get right into it. So first of all, Mandy, tell me all about at Open Gate. What do you all do at Open Gate, and what's the mission and purpose, and how did you all get started over there?
So Agency Domestic Violence Shelter and Services has been the primary service provider for survivors of domestic violence here in New Hanover County since 1986. It started when two smaller agencies who were doing similar work joined forces. And so it sometimes can feel like we have so far to come, still really far to go in this work, but it's amazing when I think that in my lifetime, there was a moment when there was not an agency that served survivors here in New Hanover County. And so we have come a really far way in a relatively short amount of time, but there is still a lot of work left to do. We provide wraparound support and services. And so even though our name says domestic violence shelter and services, many of our clients are not in need of emergency shelter. And we don't want that to be a barrier for folks reaching out. So we provide 24-hour crisis intervention, emotional support, safety planning is a huge component of what we do. And then working to connect survivors with other community resources and referrals that will help them along their journey. Our mission is really based in empowerment. I think on the outside, so many people have an idea of what they would do if they were experiencing domestic violence or what survivors should do. And as advocates, we know it would be very simple if solutions were one size fits all, but they are not. Each survivor has a very unique set of strengths and challenges that they're navigating. And so in a similar way, our responses have to be multifaceted, multi-tiered, and really we need to be prepared to meet people wherever they are. And so our philosophy is based on that empowerment and giving survivors agency and choice over the next step in their journey.
So you said something that I'm not familiar with and others may not be familiar with. What do you mean when you say safety planning?
Yeah, that's a great question. A lot of times with domestic violence, the message that survivors hear is like, you just need to leave. If it's so bad, just leave. And what we know as advocates is leaving is the most dangerous time in a survivor's journey. And there are often many barriers in the way. And so as advocates, we can really listen and hear what are the challenges? What are you afraid may happen if you leave? Or what are the patterns you're seeing of violence escalating? And then we can sit down with that survivor and bring strategies. A lot of times survivors are so isolated. They are scared to share what they're experiencing with friends or family, or abusers have kind of cut off their relationships there. So an advocate can help brainstorm who are the safe people in your life you could turn to, where are some safe places you can go, even working on some more practical strategies like, you know, a lot of times I come home and I throw my keys on the kitchen counter and then my purse is in my bedroom and my cell phone is who knows where. And so just talking through some practical things like, let's make sure everything that you need to get out the door is handy and is safe and is nearby.
Okay. Oh, that is smart. I never even thought about that. Listen, as chaotic as I am, when I walk in the door, my keys over here, my pocketbook's over here, everything. But that makes sense. That is really smart. Just making sure everything that you need, if you're in a situation that could possibly be challenging or compromising to your personal space in terms of your safety, you want to make sure. I think that's a great approach for everyone. Think about just creating a safety plan, putting all your stuff in one space. So if you have to leave and you have to exit, you can go and get all those things at one time and get out the door. That's amazing. I like how you said that.
And Fawn, we practice fire drills at work and at school and in different places because we know if there was a fire, that's a traumatic situation, that's a crisis situation, and our brains are not wired to think clearly in crisis. They're designed to keep us safe and keep us alive. And so it can be very hard if you're waiting for that crisis to happen to know what the safest step is for you. And so very much like we practice a fire drill with survivors who are in a high risk situation, we practice that safety plan. We talk through it in a safe, contained space so that if that crisis happens, it's kind of automated that response of what to do.
That makes a lot of sense. Sarah, talk to me about what's happening right now with breast cancer. What are we seeing when we have these conversations? So, piggybacking on what Mandy was just sharing to us about the incidents of and creating safety plans. When we talk about stress and when people's lives and they're dealing with breast cancer, what do we know about breast cancer?
Yeah, thank you. As a health system, we're so ingrained in treating the cancer as opposed to always focusing on the prevention. And so when it comes to talking with women about screening and preventative efforts around breast cancer, we always like to include what might it be like if you were to be diagnosed as well.
Mhm.
At our cancer center, we screen patients for social determinants of health around interpersonal violence, transportation, food insecurity, housing. We have a team of social workers that work with them throughout their treatment. Most recently, we actually have had some individuals that were experiencing homelessness and also going through domestic violence situation. And we were able to support them through staying at our family house while they were getting their treatment. So
Okay.
we know that we want to reduce stress as much as possible to ensure that they can remain healthy throughout their treatment, as it's so detrimental on their body and their mental health. So we want to try and remove all the barriers that we can once someone is diagnosed. And again, reiterate that on the front end when we're talking about screening as well.
What so in today's time, and I'm ignorant to this, so I apologize. Are there many different types of treatments when it comes to breast cancer, or are there just different standards that people do? Because the only one I really know of and I hear all the time is, oh, if I get breast cancer, I got to go through chemo. I get in. Is it various types of chemo, or is it just one standard chemo? Like, could you give me some information about that?
Yes, I will preface by saying that I'm not a physician or a
I'm
nurse,
sure.
so I'm not the expert, but there are lots of different kinds of chemo in terms of different infusions that you're getting based on your type of cancer that you might be diagnosed with. And then we have radiation therapy, and then we also have oral chemo, which some people have chosen if maybe they have a stage 1 diagnosis, then they only have to take the oral treatment, which isn't as hard on their system either.
Okay. Yeah, because I didn't know if that was just the only treatment, is that if that's the first thing that people do, but I guess it just depends upon the type of cancer that you have and determining the plan that you have and how, where you go, whether it's because I recently learned that there was a zero, like you could have breast cancer zero, if I'm not mistaken. There's 1, 2, 3, 4, stages, and then there's stage 0. And I didn't even know that there was a stage 0 within that. So that's interesting to know. Tracy, tell me about some of the services that you all provide over in Safe Haven.
Okay, sure. Safe Haven, we serve both Pender and Duplin counties. And in that, we provide a lot of the same services that Mandy listed so well. We focus on empowerment. Also, that's kind of the foundation of what we do, because we understand that we want the individual to be empowered beyond the services that we provide, so that they are able to feel that they can make healthy decisions for themselves. Because understanding in a domestic violence situation, intimate partner violence, that choice has been taken away often from the person. So just helping them become empowered and realizing that their voice matters, that they're the experts of their own stories, that they matter, and their choices and decisions matter. We do a lot of work around that. And we also do, over probably the last 3 years, we started doing a lot of, or increasing our budget, looking for additional funding to provide more emergency assistance. And that includes like rent deposits or sustainability in a home, maybe where they already are, if they have a domestic violence protection order and want to remain there. or if their housing situation was not ever compromised and they want to stay there, or if they want to relocate. We've found that that has been very successful with helping individuals not just transition from a unhealthy relationship, but to sustain that transition. So we have definitely tried to redirect a lot of our services, and again, like I said, to find additional fundings that will help us do just that, to provide emergency assistance. Beyond that, like Mandy mentioned, I think is noteworthy to say this, is that probably about 35% of the individuals we serve are sheltered clients, because a lot of the individuals we serve are in the community. They're not seeking shelter. And we also found probably maybe 3 or 4 years ago that we have to say that when we're out presenting and we're doing awareness, because that had been a barrier to individuals who were in harmful situations, but not necessarily seeking shelter. They didn't realize that our services were a fit for them. So we make sure that we express that's on our literature, and we do a lot of community outreach. We try to be present at community events and speaking to people where they are, and letting that look like what they need it to look like at that time.
I'm glad you said that. So let's do a scenario, and let's say I am that person, and I'm in a intimate partner violence situation, and I'm just not ready. I'm just, for whatever reason, right? There are for a variety of reasons. It could be I may not be mentally ready. I may not be financially ready. Whatever that situation is, everybody has a variety of things that come up. And I also, when I started this meeting, one thing I always like to start, especially when we talk about this with sensitive topics, I didn't start this way, so I want to apologize. This is a safe space, for everyone, psychologically safe, verbally safe. So if there's any questions that people want to ask in the webinar, this is your safe space. You can ask those questions. If you want to reach out to Mandy individually, Dr. Ray individually, Sarah individually, I have included all their information. You can reach out to them independently of me, and get your questions answered, and let them know, and they will communicate with you directly without any with me interceding on that half. If you would like to receive any of their telephone numbers, so you can reach out, I will give you that number. I have all the links included in this webinar for everyone that is there if you want to just get that information. But I just really want to say that this is a safe space to express your thoughts, your feelings, and what you're going through. So back to my scenario. So what if I am that person that's in a situation and I'm just not ready? Do you have people that are able to visit, with that person? Or do I have to come to either Safe Haven to get those services? Because what if I'm scared that someone may recognize me by coming to the shelter or what have you? How does that look and how does that work?
So that looks a lot of different ways, honestly, depending on what that person's needs are. So let's use the situation that they're afraid to come into the shelter, and we have an office outside of the shelter. However, it has our name and it has Empowerment Center, then Safe Haven. So certainly people identify with that. We'll meet someone. We can certainly meet in community spaces. We do not do home visits for safety reasons.
Okay.
We won't go to a home. If a person felt unsafe, we work very closely with law enforcement, and they'll do safety checks, just kind of going through the community so that to not stop at the person's home. And if they're not ready to leave, and a lot of times, of course, that's going to could increase episodes or incidents of abuse. So we don't do that. But let's say that you're not ready to leave. We would certainly work on a safety plan. That's the very first things to do, maybe identifying who safety individuals are. We've actually started doing this, and the idea is not unique to us. One of our a survivor we were working with gave us this idea. In her safety plan is that she'll send a friend, the person she identified, an emoji, and they chose what that emoji was. It was one that they wouldn't normally use. So she'd simply send that, if she sent that emoji, the friend, they had other plans in place, like then the friend was going to call her dad, meaning these victim's dad, and then they were going to create an opportunity for her to come out the house to meet with him, like for dinner or lunch or coffee, whatever time of day that might have been. And that was her escape. So we would probably look at something like that if that worked, if that was feasible, encouraging the person to in small amounts of things, moving them from the home, ordering social security cards and birth certificates and having them somewhere else, not necessarily in the home. We used to, and if it's safe to do this, we'll say just pack your important documents and have them ready to leave. But sometimes that could create question that if maybe the perpetrator, the abuser, is looking for a document and then realizes that the birth certificates aren't where they normally were, that could create that can put the person in a very dangerous situation. So we have moved to trying to encourage them to order those documents and having them at a safe place. We can be that safe place. We can hold on to those documents for them with their permission in a locked box for them. We can even pay for them so that it's not a financial hardship for that person. So again, that situation is going to look very different based on what's available to the person. And we never encourage, if a person's not ready to leave, that's okay. That is really okay. We're here when they are ready, and we're here right now while they're not, to help prepare them if they ever decide to leave. But we'll continue to give information. And the thing is that we want a person to be informed, to make informed decisions. So the more information we give them, the more empowered and informed they're becoming.
I love how you said that. And first, you got directly to the point of what I was asking, which is you don't go to home visits, because I think that that's something that some people may think that you do go to home visits. So I'm glad you clarified that you don't. And so with thinking about that, Mandy, if I am a woman and I have health issues, such as breast cancer, do you all help facilitate that person getting to their doctor's appointments if they need to get to doctor's appointments, or any of any of their health screenings or any of their medication or anything like that? How do you all facilitate that, or do you help facilitate that?
Yeah, absolutely. And we have a really strong partnership with healthcare providers in our community. And it is kind of a give and take referral system. There are times where we've received calls from a nurse in a doctor's office who said, I've noticed changes, or I have concerns based on things that I've seen with this patient. What's the safest, best way to intervene or get them connected? And in certain situations that I've worked on, I really feel like those interventions have been life-saving. And so yes, we can absolutely assist with transportation to certain things like that, or advocate with the hospital social workers and things to come up with a more long-term policy that's going to be supportive of those needs. And really, kind of like Dr. Tracy was saying, tailoring it to what that individual is going through and what their needs are at that time. But there is a ton of intersection between social health issues like domestic violence and then the medical system. A lot of times survivors are dealing with injuries that can be seen and unseen. So often we're conditioned just to think about a black eye or a broken arm or something like that. But with more severe assaults like non-fatal strangulation, there can be really detrimental lasting health implications if we aren't encouraging folks to get checked out. And so helping to work with our healthcare providers to kind of remove stigma, inform folks of what to expect when they are treated for these things, work with law enforcement on how to collect evidence. These are all systems that need to work really well together to best support folks when they reach out.
I'm glad you brought that up, because that is why I named the topic People Inside and Out. Because a lot of times when we have these conversations about domestic violence / intimate partner violence, people just presume that it's just from a physical aspect that, oh, that person may end up with like you said, a bruise or broken arm or something that you can physically see, right? But it also impacts you internally. And likewise, when we talk about breast cancer doesn't just impact someone internally. It also has its external impacts as far as it impacts the family, it impacts your community, it impacts all those that are connected to you. So when we have these conversations about health issues, it's inside and out. It's not just, only impacting one side of you. It's impacting the holistic, all of you. So so we have to be mindful that when we are thinking about health issues, that we're no longer thinking in a siloed way, that we are thinking from a broad spectrum of how this impacts. I think you led out with this when you were talking about when you first introduced domestic violence. You said no longer are we how domestic violence used to be. It's changed, the evolution of how we approach things. And that's the same thing when we talk about breast cancer, the evolution and how it's changed. I want to ask you, Sarah, recently the numbers are, as far as changing getting, what is it? It's been recommended that women start getting checked for breast cancer has been changed, and it's been lowered, if I'm not mistaken. Do you know that number?
The recommendation has always been age 40 and above. I think more women are definitely more at risk, and the American Cancer Society has changed their language around breast self-exams to be more focused on breast self-awareness.
Okay.
So that it's not just once a month, let me do my breast self-exam, but more so, let me be consistently aware of any changes with my breasts. And also recognizing that women are most aware of their own bodies. So you might go and get your clinical exam once a year, but again, that daily reminder of, are there any changes, is certainly important for women to catch it earlier. We know that African-American women actually get diagnosed at a younger age, but with a later stage of cancer most often, because sometimes there might not be comfortable doing that breast self-exam or breast self-awareness or have the education about that. So with some of our educational prevention, we're really focusing on the disparities as it relates to diagnosis, treatment, and even some of the myths and facts related to that.
I did some research, and it's interesting that you should say that, because I found out that women living in violent relationships are at higher risk for delayed screening, advanced stage cancer, and reduced change for survival. It says a history of intimate partner violence also impacts optimal cancer care receipts, such as surgery and hormone therapy. And so that's really striking to me when you think about that. But when I kind of make it make sense, I can see it, how that impacts one another. The other information that I saw was 1 in 4 women who experience intimate partner violence, their rates are higher when it comes to also dealing with domestic, when it comes to dealing with breast cancer. And you see that they have their breast cancer is a lot more aggressive when they're dealing with when they have intimate partner violence in their household. And so I see the connection between the two, and how, because it's the stress that is happening, that they're dealing with when they're going through these situations. So yeah, I definitely see that. Is there any other information that you all want to share with us that is really relevant, that we think that we need to know about the changes with domestic violence?
I'll just add that, and just because we were on a meeting with one of the reps from North Carolina Housing and Finance yesterday, is that, there's, in sustaining healthy and safe housing, that there, of course, there's a lack of inventory for affordable housing. And that's even I guess, more pronounced in rural counties, which are the ones that we're in with Pender and Duplin, is that just that we're mindful of that the need is so great for affordable housing. And I think it's a community issue. And whenever we have an opportunity, if we know landlords, if we are landlords, if we, know people who know realtors and that sort of thing, that whenever we have the opportunity that we're expressing that there's a need, and just encouraging, just maybe putting that out there. I don't really know a better way to word it. Hopefully some things will change with that, but we've seen a great problem with that increasingly over the last maybe even year and a half, but definitely this year. Individuals who are in the shelter are staying longer, obviously because there's not affordable housing. And then when they are transitioned out, unfortunately, they're making increasingly higher I'm trying to be careful with it because this is not a proven stat. But that their decisions to return seem to be getting greater because there's not affordable housing that we can even help them sustain. There's not a great inventory of that. So
Yeah.
maybe I'm just putting a plug that we all continue to outreach for that.
Yeah, I know exactly what you're saying with that. Mandy, I see your mic. Mm-hmm.
Yes, I mean, I definitely agree with what Dr. Tracy's saying. And I think that housing crisis certainly is something that survivors are factoring in when they are making their exit plan or choosing to go to a shelter or choosing to stay in a relationship. Last year, we provided 9,106 nights of emergency shelter here in New Hanover County. And like Dr. Tracy was saying, we are seeing folks need to stay for a much longer time. Over a quarter of our clients stayed more than 6 weeks with us. And so it's really hard for them to take that next step and figure out where to go safely.
Mm-hmm.
Someone had also asked a question in the chat about an increase in violence after a diagnosis, or if a survivor is a caretaker for someone who is sick. And all of those things can certainly play a role. We do work with clients who say, well, I am now the sole caretaker for my partner who is going through cancer or has some long-term health consequence. And so sometimes doctors for that primary abuser aren't aware of what's going on and are then relaying all information to the survivor, or there's an expectation there that they are going to continue to provide health care. And so that can be complicated for them to untangle from. Also, if a survivor is dependent on the abuser's insurance or things like that, and then the survivor receives a diagnosis, that can become complicated. And then even safety-wise, like navigating insurance, what information the abuser would have about the care that person is receiving. And so, for example, like we work with a counselor who we can send private referrals to. And if it is not safe for that person to use their insurance, or if they don't have insurance, then we can help, because I think counseling is so important. As advocates, I say we're kind of like co-pilots. We are along this journey with the survivor, but to have the care and support of a counselor, I think, can be incredibly valuable and validating for a survivor's experience.
That made me think about a question. How is that navigated? Let's say that you do have a couple and that person is on the partner's insurance, and they're attempting to leave. Do you try to qualify them for Medicaid or Medicare in order for them to be able to step out so they can use, services, how does that work?
So like our services are completely free of charge. And so nothing is billed because someone is reaching out for support here. And then I think otherwise it's really meeting with that person and identifying what their unique circumstances are. So whether it is we're going to help advocate for them to get their own insurance, or whether it is exploring some sliding scale options so that insurance does not have to be billed. But really kind of creative problem solving around what is best going to address their needs.
Mhm.
We also haven't talked about like immigrant survivors. And so immigration status is another huge thing abusers can use to control someone. And we see the same dynamics of power and control in those relationships, but then there is also additional fear and isolation if someone is not a legal citizen. And they're also limited on what services and supports they can receive from different places. So that's another factor we have to consider when we are working with folks.
I'm glad you brought that up. Sarah, do you know the numbers as far as New Hanover County, what we experience in as far as our breast cancer numbers?
Yes, our registry is about a year behind in terms of incidence rate for cancer, but breast cancer is the highest, with lung cancer being secondary in our area. And our cancer center, of course, expands not beyond just New Hanover, Brunswick, and Pender. You know, we see folks from Columbus, Sampson, Duplin, and Onslow counties. So breast cancer, again, remains the highest. And then with lung cancer, we're seeing that a lot with firefighters, actually. And there's a special initiative around that with the American Cancer Society. I did want to address what Mandy said, because I think it was a really good point about insurance. And we've had that incidents happen actually with individuals coming to the hospital, whether it be to the emergency department after an incidence of violence, or even if they're coming for treatment at a primary care office or a cancer center. And we've been able to work with the insurance company to do some kind of ghost billing on the account for the individual, or even just bill it via charity care for the patient. So most recently, we had a patient that was technically still listed as living at her abuser's home, and his income was too high for her to get charity care. So we were able to figure out how to show that she was no longer in the home to support that, because we don't want to add another stress of financial medical bills on top of what they're already going through.
Thank you for bringing that up. I didn't even think that that was a possibility. And see, that's why it's important to have, information sessions like this, because no one, who knew that you could do something called ghost billing, because to your point, if I'm in need of care and I go to the hospital and I'm already in a violent situation, I don't want something that's going to trigger my partner to be even more angry. Like, why did you go to the hospital? Or, I've got an additional bill that's coming inside the house, and questioning, why is this bill, and et cetera, et cetera. There's all those things, the domino effect of that situation. And I could see why I wouldn't want that person to know, that I came to the doctor. And I need my providers to be able to take in consideration of what's happening with me. So that's a wonderful thing to know, that Novant takes that extra step to help get that done. Dr. Ray, I want to also ask you before we leave, and because this is something that's near and dear to my heart, could you share with me what are the numbers that we see when we talk about youth with intimate partner violence? Is that something are we seeing higher numbers with our youth experiencing intimate partner violence? I can share with me. I know when you did your introduction, you spoke to that. I also was a victim of intimate partner violence when I was a teenager. When we were young, we didn't have those terms as date rape. That only came up, later in life, right? But I know that that's something that I experienced when I was in my first relationship. And I didn't have the language for, putting it to that this is actually what I went through, and the control that I went through with that particular person, and not understanding that this was actually a violent relationship that was in. And now it takes me as an adult, I can look back and reflect, oh, okay, this is what that was, right? So how do we, are we seeing a higher number of youth experiencing that? And then how do we educate those that are watching about signs to give them cues on what to look for in the language to use in that space?
So I don't have like stats because we don't do a youth program right
Yeah.
now. But the stat overall from our North Carolina Coalition Against Domestic Violence, about 1 in 4 girls will experience intimate partner violence by a partner, by a boyfriend or girlfriend. For males experiencing it, being the victim on the victim side of it, it's about 1 in 7 or 8. And Mandy, please jump in if you have any more updated information with that. We used to do the Safe Dates program in the schools, but we Safe Haven meaning is not doing that right now. So we don't have those actual numbers of like maybe how many in North Carolina teens have disclosed abuse or
You're right. I found that it's 1 in 4 men. You're right.
But is it 1 in 4 men? Okay.
Yeah.
Thought it was a bit higher for that, for the men. And the interesting thing, we talked about this last night at our vigil, and I used to do this when I did the program in the schools. It would be interesting to have like maybe 4 girls in the classroom stand up and then maybe 1 girl separate, just kind of take a few steps aside, and then just show that statistic in real life, like what that would look like. Is very sobering. It's sobering for us as adults to even see that, because we're parents or grandparents of youth who are in the schools and are in that age group who might be experiencing abuse or an unhealthy relationship. And I will say this, whenever we get a parent and an older child into the shelter, or we're working with them and we're working with the adult parent, the adult in that situation, more often than not, if the younger person is in a dating situation or has experienced dating on any level, they have experienced some level of unhealthiness in that relationship. There is a really awesome quiz. It's probably like 10 questions or whatever that will just give a scope on if you've answered yes to 1 or more of these questions, you may be in a harmful or unhealthy relationship. And that's always a really good guide. More often than not, young people are I shouldn't say young people, but in teen dating violence or younger intimate partner relationships, the violence, it goes unnoted, unfortunately, for a significant amount of time. And largely because it can look like the person's just all about me, that, he or she just really loves me. But the constant calls of wanting to know your location, stalking appears to be, again, that this person is just really concerned about me. They just really want to be with me all the time. And we know that those can be red flags to an unhealthy relationship.
Wow. Mandy, did you want to add to that?
Yeah, very much all of those things that Dr. Ray shared. We are currently working with the CDC. They have identified domestic violence as a preventable societal disease, which is a very cool and progressive way to look at this issue. And so one of the projects we're working on over the next 5 years is developing a teen advisory council made up of young people from all across our community to tell us what that looks like amongst their peers, right? Things have changed a lot since I was a teenager. And so it's important that we're not going in to start these conversations with teens without first asking them what it looks like and what it feels like. Through technology and social media, it's just such a different landscape now. I think starting early with kiddos about setting healthy boundaries is so important, because when you're in these first formative relationships, it's not always intuitive where to set those boundaries. We're seeing, when we talk to kids, they're saying like, yeah, if you're in a safe, committed relationship, of course you should share all of your passwords with your partner. Of course they should have access to your phone 24 hours a day. That's how we show trust. And that's really scary for us to hear, because we know that in a healthy relationship, your boundaries should be respected and you shouldn't have to be proving yourself by having a partner go through your things. And so that's normal for a lot of kids these days. So the earlier we can start these dialogues, the better.
Yeah, I definitely agree with you 100% with that. Sarah, did you want to add anything to that?
Yeah, I heard earlier where Dr. Tracy mentioned, that men can also be victims of domestic violence. And I always like to point out that men can also be victim to breast cancer.
Mhm.
It is less than 1% of the rate of breast cancer, but it is still really important. And we like to ask that if you all think about your brother, your dad, your uncle, your neighbor, to remind them that they can also be at risk, and thinking about, breast cancer in men.
I'm glad you brought that up because my stats that I have here says that Black men with breast cancer tend to have a worse prognosis for men when it comes to them dealing with breast cancer. So basically, that when they are diagnosed, that their prognosis actually does turn into a not great situation when they are diagnosed with it. And I also have nationwide about 530 men will die from breast cancer nationally. So it's important. So every person that passes from it, we don't want to lose a life at all. So it's important that we have that. I want to open the floor to any questions. If anyone has any questions for Sarah, Mandy, or Dr. Ray. And while we're waiting for some questions, Mandy, tell us about the Fathers Program that you all have over there.
Yeah, absolutely. So I think it is so important that we engage men in the movement to end violence against women. Like we've acknowledged, anyone can be a victim of domestic violence. And so unfortunately, that certainly can include men. Last year, we provided direct services to 53 men in our community who were identifying as being victims. And so casting with a wide net, I think, is really important. But a former prevention specialist, Dr. Rick Houston, who's wonderful, said, if women could end violence against women, then we would have, because we're strong and we're resourceful. And most men are not abusers. And so it's important that we acknowledge that. But if we look at 10% of men or some estimation like that who perpetuate some form of abusive behavior, it's 90% of men who just say, well, I don't do that, so I'm okay. But we need to lean on that 90% to hold the other 10% accountable and really change this culture that violence against women is not tolerated. And so Fathers for Hope was a way to acknowledge men in our community who are doing outstanding work, to acknowledge that domestic violence is a problem in our community, and take steps to engage other men around that.
I love that initiative. I went on your website, and for those who would like to learn more about it, if you would go to, I put the link within domestic violence, so you can learn more about Fathers. Could you state the name of the program?
It's Fathers for Hope.
Fathers for Hope. And then that way you can get more information. And they have a whole list of men that have participated in the program. And I really, really like the program a lot. We do have a question or a statement that has come in from an anonymous person. And it says, as someone who works with DV survivors, I have noticed when assessing services or resources from other professionals that there is a lack of empathy or sensitivity to how difficult it is to move forward, especially when the perpetrator has been the sole income earner and has isolated their partner. To be asked how someone will financially sustain next month when a person just left the most traumatic environment and is thinking just survival at this point. And I have to agree with you. That is something that I think a lot of people actually deal with, I don't want to say a lot of people, a lot of people in this situation. That's a clarifying statement, contextual statement, that when you're dealing with intimate partner violence and you are trying to navigate, and in my mind, and because I have not dealt with this as an adult, in my mind thinks that I'm only thinking about my situation now. I don't have the capacity to think about tomorrow. I'm trying to think about now. And I think that there could be more empathy, more compassion, more grace from providers to when it comes to how does that person move forward in what they're doing, and not just automatically assume that they have a plan because they're leaving and they're thinking about the now. They're thinking about safety, especially if there may be children involved in the situation, or if there may be there could have been a caretaker to a elderly parent, and they're trying to get, so it's many dynamics that they're coming to it, and you don't have that sympathy for that person or the empathy for that person, and them trying to get their feet under the ground and how to move forward. Did you all want to comment towards that statement?
I'd like to just respond and thank you for the comment. And unfortunately that does happen. And it is it's so unfortunate. Whenever I have the opportunity to speak to groups, especially in the community, or groups that are not familiar with the work that we do, and I lead with this activity, and it's not unique to me. I'm not sure where I even picked it up, but it's a bad job activity. And I'll ask everyone in the audience, just to get some participation. Have you ever had a job that you would consider a bad job, one that you didn't like, but you continue to go to it? And of course, several people, including myself, raise our hands, and then we'll discuss that. I said, well, why did you go to that job? Why did you continue to go? And of course, you got financial security, insurance. It was familiar. I knew how to do it, et cetera, et cetera. Whatever and they're valid reasons, really valid reasons. And then I said, while it pales in comparison, consider that those are the same reasons amplified why victims remain in abusive relationships, because of their children, because of because this person is the financial means for that family, et cetera, et cetera. And then imagine leaving all of that, just being swept from under you. Could you even imagine being able to process in that moment? And we try to be mindful of that as advocates when a person is receiving services from us, that we don't do a whole lot of intake and a whole lot of information on the first few days, because the person cannot even process that. The goal is that for the person to have time to be mindful and know that they're in a safe space, that they have individuals who are here to advocate. And I love what you said, Mandy, to co-pilot with them. We're going to use that. So, but just to be with them on that journey, we just to give them a moment to reflect on that, but to make major decisions or even any decisions at that very quickly after that is extremely difficult. As practitioners, as advocates, we have to stay in training. We have to continue to evolve. A lot of times, unfortunately, practitioners are burnt out, are dealing with compassion fatigue, and these are not excuses, but just some understanding. And as a practitioner who is in the work because we care about the individuals we're serving, it is our responsibility to stay in training and take breaks when we need to take breaks, because it's extremely unfortunate when survivors have to deal with the slack of our tiredness or just our unprofessionalism.
And so, Grace, okay, so the person commented that they thank you for Grace, but I have to agree with you that it is exhausting. So I want to end on a high note. I'm going to show this slide quickly, and then we'll end. I did find a slide that I wanted to show to everyone, just how the intersectionality of it all is actually working. And then we'll end on there we go, a high note. Let's see. So I did find this slide, and it said that 48.5% of cancer patients report a history of violence in advanced stage diagnosis, and it correlates with intimate partner violence history. And many of them have limited access to care services, delayed screening, diagnosis, treatment, and a greater impact for women. And it has a greater impact for women living in poverty. And so, so as we know, October is pink and purple are together for a reason. So, I just, so if you ask, if you're wondering like, well, why did Fawn decide to put the two together, the two together? This is why, because there is a strong intersection between the two of the actual issues. And I just wanted to make sure that we brought light to those. But with that, can you all share with me something that you do? Let's start with Mandy, since she's at my bottom. Mandy, share with me something that you do to bring you joy.
Oh gosh. Spending time with my kiddos is very rewarding and renewing for me. And so at the end of the day, we try to go for a walk through the neighborhood and share the highs and lows. And their favorite thing right now is creative problem solving. So they'll ask me like what a challenge I had that day was, and they'll try to come up with solutions for it. And so that brings me a lot of hope that our next generation has a good head start at figuring things out.
Okay. And we're going to go to Miss Sarah. Share with me something that brings you joy.
I mean, I would echo that. I love spending time with my kids and my family, exercising. I have a 4-year-old and a 7-year-old boys. So there's always some kind of mud or lizards or snakes in my house that always just create some type of laughter.
Oh gosh. Well, just remind me never to come by, because I'm not a lizard. I'm not a lizard, a snake kind of girl. And Dr. Ray, share with me something that brings you joy.
I love spending time with my family and the
Yes, you
holidays.
are.
So this is my peak season.
Yes. Y'all, Dr. Ray is a family person. Let me tell you. They have a big family and they are not ashamed to gather. So, well, let's look at this last comment real quick. It says, the job comparison, Dr. Ray, is a really good one, because at the end of the day, we are all creatures of habit and we are great at adaptation. And ultimately, we do tend to settle for countless of reasons. Like Fawn, I was in a domestic violence relationship when I was very young. And I know that for me, I used to see my boyfriend as the victim, because he was the one who came from the other side of the tracks. He was the one I saw as an underdog, and I wanted so desperately to help him. And after the beatings, he would threaten to commit suicide. I must have had the same boyfriend, Marissa. So it was a vicious cycle, but thank God for the resources that exist for women today. And I truly believe that only those of us who have been victims of domestic violence truly understand the complex psychology surrounding the relationships between the victim and the abuser. I couldn't have said it better. I definitely understand more than after this. I have to call you, Marissa, and tell you my story, because I totally understand that all too well. So thank you for sharing your story. I really appreciate it. Ladies, thank you so much for joining us. We are 1 minute over. This is touchy subjects, and but we want to make them more easier subjects to have, easier conversations to have, more open conversations to have. We shouldn't hide them. When it comes to our health, we need to be more proactive in having these conversations on a regular basis, and we should not be having scared conversations. We should be having free conversations, safe conversations, and welcoming people to the table to have conversations from all walks of life, no matter how you identify, so you can live the most optimal health, however you define it. And that's what health equity is. Health equity is the opportunity for you to have the optimal health, however you define it. And that's in whatever space. That's being free from living cancer-free. That's what we're hoping, and to live without having intimate partner violence, and however that may look, whether that's mental manipulation that someone may be trying to do to you, or physical violence that someone is doing to you. So we thank you so much for the opportunity to speak with you all today. And I hope you have a wonderful holiday season if I don't see you all before the end of the holiday season. Thank you so much.
Thank you, Fawn.